Okay, so good morning, everyone, and welcome to the Making the Connection Conversations Around Integrated Care webinar. I'm Yvette Kelly with the Managed Care Technical Assistance Center, and today I'm joined by a few of my MCTAC colleagues, as well as a number of our partners who you can see here on the slide, with whom we've been collaborating with to bring you what is now the fifth offering in the Conversations Around Integrated Care series. For those of you who've joined us previously, we're happy to see you back. And for those joining us for the first time, we're happy to have you. If you're interested in hearing more after today's presentation, please consider joining us for our April offering. And we will also provide the link to our past presentations in the chat shortly. And so many thanks to all of our partners for helping support this work. To our next slide, please. So here's a look at our agenda today. So we're going to begin with, of course, the welcome and just some brief introductions. And we are going to ask that our presenters just provide a really brief introduction prior to their portion of the presentation. We'll then talk briefly about the purpose and format of this series before we hear from Dr. Daniel Deutsch from South Beach Psychiatric Center, who was with us last month and has joined us again today, and Dr. Grace Hennessy from OASAS, who will be leading us through our topic area for the presentation. After the presentation, we will open it up for Q&A, so please feel free to chat in any questions or comments that you may have along the way, utilizing the chat box, and we'll make sure to address them. And then lastly, we will be asking you to complete a brief survey at the end. We do look forward to any feedback that will help us improve these presentations, so if you can just take a few minutes at the end to complete, we would greatly appreciate it. Next slide. Okay, so just a little about today's series. So these presentations were really born out of a desire to support providers in exploring different strategies and approaches to promoting integrated behavioral health care, as we recognize that these approaches really work to improve treatment outcomes and reduce costs of care. The goal is really to be able to present an example from the field, as well as highlight some key topic areas that not are only relevant to the case discussion, but also to the overall service provision in the field. And so we hope you find this presentation helpful and informative. And again, we will be chatting in the link to past presentations so that you can refer to them if you so choose. And again, we do have one more presentation for next month, so we'll ask all of you to join us. And with that, we're going to pass it over to Dr. Daniel Deutsch to provide us again with a brief introduction and to get us started with today's presentation. Thank you.
Hello, everybody. Nice to be back. Excuse me. So this is the case of Oliver. He is a 44-year-old African-American male, and he was born and raised into an intact family. He is of Nigerian descent. He has a pretty clear timeline of events at around the age of 9. Around the age of 6, we think he started to exhibit some behavioral issues. By around the age of 9, he was removed from the family due to physical abuse, placed in foster care, subsequently placed in the care of an aunt as next of kin. Ultimately, at the age of 12, he was returned to the family home. Around the age of 13, he started to use alcohol, possibly with his brother. We suspect that, but we don't have, actual confirmation. At the age of 15, he started to smoke marijuana. And in his late teens to early 20s, he started to use crack, and probably fairly regularly took over quick. After that point, he graduated high school, which is pretty remarkable, and he did enter the Army, but he was discharged very quickly because of drug use issues. After that point, his history seems to go fairly dormant, although, I think it's reasonable to presume that he was using drugs all along. But at around the age of 35, we see a confluence of issues come to a head, and that would be the onset of psychiatric problems and contact with local providers, arrest history, which continues up to this day. He has about 25 arrests on his record, but only 2 major felonies. And also, the drug use came to the attention of treatment personnel, which, I guess indicates that his use had gotten to the point where it was no longer controllable. The interesting part is that you see this big gap in the record, if not necessarily in his life, between 20 and 35, where things were quiet. He graduated high school. He was able to, I think, work a little bit, according to his mom, even enter the Army and of course get discharged. But he came to our attention at South Beach in 2018 with his first and only contact with the state for long-term care at this point. He was discharged in 2019 to a MICA residence called Chait Residence, and was followed by the OVL clinic, which is where I'm working. In addition to the state clinic for services, he was receiving care coordination services with also South Beach. And his care coordinator was very, very good all along. We each know the family for a long time because we've not only treated Oliver, but we've treated his brother. And because of that involvement, we also have extensive contact with the family. So Oliver was in the clinic. He was doing well. He responded quite well to the structure. After about a year, the pandemic hit. Restrictions were imposed in the residence, as they were in many other places. And he really did not take well to that, wanted to get out, and he self-discharged. Once he hit the streets, his crack use just took off, probably to pre-treatment levels. And we suspect that his brother had something to do with that because they often use crack together. And in the past, the brother has enticed him into crack use once again. So while he was with the clinic, most of the time he made his appointments after his self-discharge with the help of his care coordinator. And he did very well psychiatrically. Whenever we've met, he was very clear and responded well to the typical antipsychotic. I believe he was on Prolixin initially, and he was transitioned into Invega after about 6 to 8 months after, because it was felt that an atypical would work better, particularly given the crack use. And he still remained very, very clear. He was sent to the ER a couple of occasions for psych eval, was not admitted. And when I spoke to him as well, his psychiatric status was very good. It's just that, his crack use was really out of control. A number of attempts were made to place him in rehab with no effect. He, on the one hand, he had burned a lot of bridges. So a couple of the rehab programs really weren't interested in working with him again. And also at the 11th hour, upon referral to a rehab, he would back out. And so there were a couple of failures even before things started because of that reason. I'd have to say shortly after, so that's kind of where we left off at the last presentation. But shortly after that point, Oliver refused all further contact with his care coordinator, which was kind of surprising since she was, fairly close with him. And he also dropped out of treatment with the clinic. We have had no actual contact with him for a good couple of months now. And as his high-risk status dictated, policy indicated that we have to close this case a few weeks ago. And his case was ultimately transferred to the SES agency, which does follow up for cases that are unsuccessful or lost to contact, and which is where we stand now. Obviously, if he comes back into the system for treatment, we will take him back without any issues and resume where we left off. But as of right now, his case is closed, and he is we don't know where he is. The real concern, of course, is that he's dead at this point and hasn't made it, but we haven't heard anything from the family to that effect. So we're assuming that he's still out there. And if he deteriorates to the point where he gets, where he needs psychiatric help, he'll come back into the system and return. That's pretty much where we are at this time.
So thank you. Wanted to thank you, Dr. Deutsch, again for coming back, for presenting Oliver's case a month ago when we first met him in this way, and for coming back again to update us, go over the case for people who were perhaps not at the last meeting, and to update us on where he is today. So next slide, please. So in light of what was going on with Oliver, and one of the questions that Dr. Deutsch asked when we first met with him back in February to talk about this presentation was about how do you kind of work with people who continue to use. So it sort of led us to thoughts about person-centered treatment for patients with co-occurring disorders. By the way, I'm Dr. Grace Hennessy. I'm the Associate Chief Medical Officer for Addiction Psychiatry for OASAS. And we wanted to review some of these issues today with you, and then have a larger discussion about person-centered care, particularly when people continue to use and are living with co-occurring disorders. This is going to be a shorter presentation today. And again, hopefully we will have more of a discussion in the chat and talk more about Oliver and his care in case if he does come back to the clinic. Next slide, please. I have no disclosures in relation to my short presentation. Next slide, please. So in November of 2019, OASAS issued the person-centered care guidance for our certified programs in response to issues about patient care that were raised by our providers. The guidance includes the following principles of person-centered treatment for patients served by our programs. So for first point, person-centered treatment plans should be developed using an individual's own language to identify treatment goals. Plans should reflect the individual's values, culture, and belief. Person-centered treatment planning includes working with individuals who may have treatment goals other than abstinence. This includes reducing risk and minimizing risk associated with substance use patterns. Individual goal setting should reflect shared decision-making and informed choice. Every individual seeking services should be informed of the comprehensive array of available treatment options. Individuals should make an informed choice regarding medication and behavioral approaches to treatment. The multidisciplinary treatment team maintains a professional role by informing treatment planning and assuming ultimate responsibility for the plan. And person-centered treatment is evidence-based, strength-based, and non-punitive. And while all these principles are important, next slide, please, what we'd like to highlight today is actually what is highlighted in blue on this slide. So it's the same slide as the last one, same principles, but really wanted to hone in on that person-centered treatment planning includes working with individuals who may have treatment goals other than abstinence, which includes reducing use and minimizing risk associated with substance use patterns. Before I go on, I have one other disclosure. I'm not sure if you can hear, but I have a very noisy radiator. I see Yvette is nodding her head. I have no control over this. I am in my office in Midtown Manhattan, and the heating system has a mind of its own. So hopefully it will not knock for too long. I also have a stage voice, so hopefully people will not have trouble hearing me. I can speak louder if I need to, but I do apologize. So any knocking and pinging you hear is my office radiator. Next slide, please. So let's start first talking about harm reduction for all people who use substances before we get into co-occurring disorders. So what harm reduction looks at is practices, programs, and policies that aim primarily to minimize the adverse health, social, and economic consequences of substance use. And this can take a lot of forms. So one would be medications for addiction treatment. So in the case of Oliver, if you looked at his medications, he was prescribed Naloxone, which is a medication that we use for alcohol use disorder primarily. It can also be used for opioid use disorder, but really it's primarily used for alcohol use disorder in its pill form. The long-acting injectable form we use for opioid use disorder. Other issues in harm reduction would be non-abstinence-based housing and employment initiatives. So if you house people, hopefully they will do better and make work towards their goals in their lives. And that may include reducing and ultimately abstinence, and again, employment initiatives, syringe services programs, overdose prevention centers, overdose prevention and reversal education. So teaching people about naloxone in particular and how to use it. drug checking, such as with fentanyl test strips, and really no single definition or formula for implementing harm reduction exists, since harm reduction informed approaches focus on the specific individual and the community needs. Next slide, please. So harm reduction, again, some more issues in terms for people who use substances. So the characteristics are targeting risks and harms to those who use substances, understanding the roots of these risks and tailoring interventions to reduce them, acknowledging the significance of any positive change made in their lives. So, if people even reduce their use a little bit, or maybe they change the way they use, the way in which they're using, maybe they're injecting and now maybe they change to snorting. That's something that you can acknowledge and say, this is something positive that you're doing to reduce your harm from substances. Accepting people who use substances as they are, meeting them where they're at and treating them with dignity and compassion, protecting the human rights of people who use substances, and maintaining transparency in decisions about interventions, as well as their successes and failures. So again, if you're talking to people about different types of treatments, you want to be honest with them about what might work, what may not work, and particularly given their particular situation. Next slide, please. So thinking a little bit more about individuals who have co-occurring disorders, one way to address harm reduction for them is to think about using evidence-based treatments for integrated care. So in terms of non-medication therapeutic interventions, there are evidence-based group therapies that address co-occurring conditions. So probably the one that's been around the longest and people may have heard of is Seeking Safety, which is a treatment manual for PTSD and substance abuse, which was authored by Dr. Lisa Najovitz. So again, that's one for individuals with PTSD substance use. And, we don't know everything about Oliver's story, but we did wonder, is there some kind of trauma in his past or even in his present? I mean, clearly, what's going on for him, there's probably trauma going on if he's living on the streets, he's been assaulted. So he may need a trauma-informed and a trauma intervention to help him with this substance use. There's also integrated group therapy for bipolar disorder by Dr. Roger Weiss and Hilary Connery. That's a 12-week manualized therapy for people with bipolar disorder who use substances. And although being female or being a woman is not a co-occurring disorder, there is another great manual that I do like to mention in this talk, Treating Women with Substance Use Disorders, the Women's Recovery Group Manual by Dr. Shelly Greenfield. And that is not a manual that really looks at, again, co-occurring disorders, but it does look at issues that are related specifically to women. Some of the chapters in it are about managing mood and anxiety and eating problems without using substances, to sort of give you an example. And a lot of these, again, go for 12 weeks, maybe longer. Sometimes you have to start with them, so they kind of build week to week. So unfortunately, you need to start at week 1 or 2 to be involved in it. But really what we found over time, and what a lot of people do, is that if you can't do a tailored group with someone, and particularly if there's someone who don't come to treatment all the time, you can pick a chapter. Work with someone individually on a particular issue that's related to a chapter in one of these manuals and try to help them along that way. The women's group is a little bit different. That one does have a rolling admissions process, so to speak, so you can join that group process at any time. Again, whereas Seeking Safety and integrated group therapy tend to build on one another. So if you are doing them as a group, those usually have to have a group that starts together. But again, as I said, you can do individual chapters that may suit the needs of your patients. Next slide, please. And then to mention medication issues, if there are prescribers on the line, or if there are clinic directors who are hoping to convince their providers to prescribe MAT. I think it's just really important that anybody who can prescribe be able to prescribe medications for addiction treatment. So in terms of opioid use disorders, it really, you do need to become X-waivered to prescribe buprenorphine, but there are a lot of MAT options. And so people should have a good awareness of them. Methadone, you cannot prescribe. Those can only be administered or dispensed at methadone clinics. Buprenorphine we mentioned, but there are other treatments. So there's a camprosate, disulfiram or antabuse, and naltrexone for alcohol use disorder. We mentioned already that Oliver takes naltrexone, and tobacco use disorder medication. So you can offer people different options. And also you want to prescribe medications to treat the psychiatric disorder. And this is where things sometimes get a little controversial. Sometimes when I talk to physicians, they get very nervous about prescribing medications to people who are actively using. Happily, this is not the case for Oliver. So a psychiatrist is prescribing him medications, which is great, because untreated psychiatric disorders can result in ongoing use. overdose. So it's really, really important that those symptoms are addressed. You do have to be cautious. You want to be careful about certain combinations of benzodiazepines, Xanax, Klonopin, and what we call the Z drugs, which are the sleep medications, so Ambien, Sonata, and Lunesta. You want to use them with caution. People who are using opioids or drinking alcohol, really avoid them because they can increase the sedation of the opioids and the alcohol. And you have to be careful about cardiac effects with certain medications. So some medications kind of mess with your heart rhythm, so to speak, you know, your EKG, and they do something, they prolong your QTC interval. And those medications you sometimes have to be careful with when people are taking methadone or other medications or using certain substances. Cocaine is one of concern. So you do need to be cautious, but not to treat is not the way to go. You really do want to help people with their underlying psychiatric conditions. You want to discuss the benefits and risks of the medications, including interactions with substances, which is very important. And you want to document those discussions and the rationale for why you chose the medications, particularly, you know, if someone is actively using, you want to be clear in your documentation why you're doing it. And then provide practical advice about taking prescribed medications. If people are using substances, have people contact you if they were not using and started again to discuss current medications. I found over the years, most people stop their psychiatric medications or any other medications they're taking, not just the psychiatric ones, when they get into a phase of active using. So, you know, you want to be able to talk, you want to be available to them if they do stop and they have a depression and they need to go back on their medications about how they can do that. Next slide, please. And this is just some other information I wanted to pass along about providing overdose prevention education, naloxone kits or naloxone prescriptions. On the OASAS website, we do provide virtual naloxone trainings at the overdose prevention site there. There are pharmacies where naloxone can be accessed without a prescription. So people can go, they can speak to the pharmacist, ask for naloxone. There is a list of available pharmacies in New York State at the newyork.gov site that you can look up. There's also opioid overdose prevention programs around the state, and they will give out naloxone as well as part of their job. They teach people how to use naloxone, and there is a list of their programs can be found on the AIDS Institute New York site. If people are injection drug users, you do want to speak to them about syringe services. There's a lot more available in New York City in terms of syringe services programs than the rest of the state, but hopefully that will change in time and people will be able to get the supplies that they need. Again, there's a list on the nyc.gov site for what's in New York, and there's also a link for frequently asked questions about the sites. These programs can also provide fentanyl test strips. So that's one way people can access and get fentanyl test strips so they can test their drugs. They'll teach them how to use them. Fentanyl test strips can be ordered outside of New York City by someone who's using substances through a company called New York Distro. So Next Distro actually sends out safe substance use kits for people, which includes fentanyl test strips. And again, New York City has a great information on their website about how to test your drugs using the fentanyl test strips. If you are an organization or a clinic or a hospital that's been previously awarded federal funding through SAMHSA or the CDC's Overdose Data to Action Cooperative Agreement program, you can actually use those grant funds to purchase fentanyl test strips as long as doing so aligns with the purpose of your grant. And you can order fentanyl test strips, not just with grant funds, you can order them anyway, but again, things cost money. So it may not be something a clinic can do within their budget, but if they can, BTNX harm reduction is a place where you can buy fentanyl test strips for your clinic. Next slide, please. And then just on the last slide, another thing that sometimes people have kind of struggle with in talking with patients is about talking with them about safer drug use, because we feel like, gee, we're clinicians, we're supposed to be telling them not to use drugs, we're supposed to really toe the line with that message. But if people are going to use, we really need to meet them where they're at, as we said, and really provide information about safer substance use. So some examples: start with a lower dose and go slowly when you start using, especially if you haven't used in a while. Test your drugs before you use them if possible. Get trained in overdose prevention and keep naloxone with you, or with you or others are using heroin, other opioids, or substances that can have fentanyl mixed in them, such as benzodiazepines, stimulants, and MDMA, which brings up a good point to just step back to for a minute about what Dr. Deutsch mentioned before. Part of the concern about Oliver is that he may have passed away. There are many reasons why, if he was using, he could have passed away. There are many reasons not related to his use that he could have passed away. But one of the main concerns that we all know about is that all the drug supply, not just the opioids, really have fentanyl everywhere. If you've watched the news recently, there was a story about spring break and a group of West Point cadets who were spending their spring break in Florida, and they purchased from a dealer what they thought was cocaine, but actually it was laced with fentanyl. And they all had an opioid overdose, and some of them were in serious conditions. So, so someone like Oliver may think he's getting crack or powder cocaine, but he may be getting it laced with fentanyl, which is of concern. So, we do talk a lot about opioids, but in terms, in general, but again, it's all about all the drug supply. So anything that people are buying on the streets may be contaminated or adulterated with fentanyl. Encourage people to use with a friend or call Never Use Alone before they start using, so they can stay on the line with them. So there's the number there for Never Use Alone. So Never Use Alone is a very interesting organization that has set up so they can be there with people while they use. And what you do is you call the hotline number. There is an operator, it's a volunteer who works there, and they'll ask for the individual's first name, their exact location, the county, and the number that they're calling from, and the substance that they're using. The operator will stay on the line with them while the individual is using. And if at any point they don't respond, when the operator speaks to them for 30 to 45 seconds, the operator will notify emergency services of an unresponsive person at that location. And it's actually quite important that they use the term unresponsive person, because reporting an unresponsive person reduces the chances of actually police responding. So if you say someone OD'd, the police may actually show up, or an unresponsive person, you'll get the EMS. So the people can feel safe that they may not get in trouble, legal trouble, for their substance use if help has to be called. Other things to share with people to encourage them to find a safe place to use if possible. Don't share your equipment and use sterile supplies. Don't mix your drugs, especially sedating ones like opioids, benzodiazepines, and alcohol. And eat before you use, and drink water or juice when you're using. Again, just simple things for people to reduce their harm and to keep themselves as well as possible while they're using. Next slide, please. And I'm pretty sure that's my last slide. So I wanted to say thank you again to Dr. Deutsch and the team at South Beach for being willing to present not once, but twice to this group, and to share what's going on with Oliver. That's me, in case anybody wants to reach me. And next slide. I don't know if in the immediate anybody had any questions they wanted to put in the chat box. If not, we were going to move on with some questions for Dr. Deutsch about ongoing care for someone like Oliver.
Thank you, Dr. Hennessy. And again, just want to remind folks that if you have any questions, please feel free to chat them in the chat box, and we'll be happy to address them. And if not, sometimes there's a little lag, so we'll give a couple seconds just to see if we get any questions.
Sure. So yeah, we'll move on a little bit, and then we can always jump back to questions. So so Dr. Deutsch, you were mentioning that if Oliver comes back, you would welcome him with open arms, so to speak. The clinic would. What is it about the way you practice, or what is it about the setup of the clinic that makes you say something like that? Or what is it about Oliver? Where does that come from?
So that's a question, I think, in two parts. Number one, I happen to like Oliver. He happens to be a very nice guy. So, whenever he's rolled through, he's been very easy to work with. He's very pleasant. And he's, when he's straight enough, he can engage in sessions. So there's that on his end. But, with the clinic, we are the state, and we will take anyone and everyone, and that sort of inculcates an attitude of can-doism, if that's the right term for it. So I think it's in a good way, it's worth it to work for a bureaucracy where you are expected to handle many different kinds of cases of differing severities. And you know, was not ask any questions about why you've dropped out of treatment and now you're back. So I think that there's an institutional attitude of acceptance that gets trickled down to the line worker.
Mhm. Great, thank
And
you. Keep going.
you know, the system that we have set up here, also you got to remember, for someone, let's say like Oliver's age, he's in his close to his mid-40s now. So he's unusual in that he's only had one contact with the state so far, but a lot of people his age have had multiple contacts with the state, you know, either because of police contact or hospital contact or what have you. So most people we expect to come in and out over time. You know, they'll be stable for a while, maybe they'll drop out of treatment, but then they know to come back to us. So this is not an unusual type of situation that we're dealing with. And also, can you hear me and see me? Because my internet's unstable.
Yeah, we can hear
We're
you.
good? Okay.
Yeah, you're
Yeah.
good.
Mhm.
Okay. There's also the, maybe my boss could speak to it a little bit more, but when a person is discharged or has lost the contact from an outpatient clinic with the state, there is another state agency that takes over and tries to track people down, find them and reconnect them to services. You know, this happens a lot because we have a fairly, in our population, we have a fairly unstable or chronically unstable, somewhat low functioning population. And so this agency, I guess, was put into place to fill the gap between, you know, the ending of one treatment and the restart of the next. So to make sure that there's connection. So that's been pretty valuable, I think, over time. And we have had people that were found by SES and have been reconnected. So there's that.
Yeah, I'm sorry. No, in his case, they haven't been able to locate him yet because they keep documenting their efforts still on the Mars record. So we are able to see that.
Mhm.
But there's someone looking. You know, in years past, excuse me, it would have been just, let's wait and see what happens.
Mhm. Mhm.
So,
Yes.
you know, there's that.
Right. Yeah.
So, I mean, do you want me to speak about when someone comes back to the clinic after hiatus?
Yeah, sure. That'd be great. We do have a question in the chat box, but we have a lot of time. So why don't we'll finish up with the, you know, the idea. So, you know, so Oliver shows up tomorrow. Unfortunately, it sounds like he's been discharged. You know, what process does he go to? Are there ways to make it easier, sort of be more person-centered? Because, you know, I know for myself, my background before OASAS was the VA, and a patient would go away for a while and then come back, and we'd be like, oh, we have to do your whole intake again. And they'd be like, oh, you know, they'd get all upset. And, you know, so we would try to do the best we can, but, you know, the VA can be the VA. And I don't know if that's your experience, but, you know, just thinking, and I'm sure, you know, other people have run up on the call, at the webinar, have run up the same issue. You know, someone comes back, and how do you kind of start them over again after they've been discharged? And how do you meet them in a person-centered way?
Do you want me to answer that, Danny?
Well, either. I really wanted to address the paperwork issue because I have a love of paperwork. And I actually asked for more paperwork when people come back. So, but anything else, I can step back.
Yes, when if SES is able to locate them, that they've been pretty good at it. They contact us for our earliest appointment available, and we provide that, and then they give the appointment to the client, and they will come. They will have to do the entire intake as the new admission because the rules haven't changed to adapt for this to happen in any easier way. And also sometimes their conditions change so much that gathering all that information in the beginning is necessary, of course, because we can see the record, we see what we already have, so we can go a little faster through that and not make it that painful for them during the interview process.
Thanks, Jeanette.
Mhm.
So I guess what do you do with somebody who comes back as a clinician? How do you, honestly, if you're talking about the person-centered approach, that's kind of already built in for the most part. Someone comes into the clinic, yeah, you have to do your intake again, but on the other, a lot of it's not too bad because it's already in the record. But yes, you do have to do another intake, but it's almost as if you've never really lost time. It's almost like you're seeing someone after, if you have an acquaintance, let's say at work, and you haven't seen that person in a long time because they moved to some other job and then they're back. It's kind of like you just pick up where you left off. There's not a lot of awkwardness or I don't think any resentment, or frustration about it. It's kind of what you do. The intake coordinator who will help the patient navigate the process may assign that person to another treatment professional because I might have just had an intake, for instance. And so I can't take another one in the rotation unless it's requested. But another person can pick up kind of where we left off because a lot of the cases are discussed in our meetings. And so hopefully we've all, kind of remembered and have a passing familiarity with the people that are coming back in.
Mm-hmm.
So,
and I would imagine you'd be available for consultation if your colleague had questions about, the care going forward.
Yeah, I mean, we all work well together here. I mean, I have to say it's a nice, tightly knit group. So we're good. I know we're lucky, right? It's good.
Yeah, well, I think you bring up a good point. Is that what's so nice about a clinic model is that even though you had worked with Oliver in particular, someone else who works there does know him, and the information can be shared, and it has been shared. You can share more, or you can help, guide someone along, and vice versa. If someone who worked with one of your colleagues. Curious just for you, and maybe open up to maybe see what people put in the chat. And Mary Peterson, I'm not going to ignore your question, I promise. But what if someone like Oliver comes back and they've been really using heavily for a period of time, and they're in rough shape, and what's it like for us? Can it be hard not to be frustrated when someone is, goes out and has been using and not taking their meds, and then here they are and they're like, help, I need help?
I think that there's a couple of things that have to be accounted for as you're going through your development as a clinician. One is managing expectations. My expectations are not necessarily that of the client. And the adage that I've learned from social workers most is that you have to meet the client where they're at, which I think a lot of psychologists forget. Or I can only speak for myself, I should say. But I've learned, I don't know if I've ever known that, but I've learned that from social workers. I think that's a very, very good way of looking at things. So I don't mean to disparage any of my colleagues. I apologize. But so that's kind of what I took away from it. Also, this is the job. You got to be able to treat somebody who's walking in your door. There's no, I mean, listen, some clients can be a pain. There's no question. But all things considered, they're walking through your door. And I also believe that if you are internalizing the person-centered approach, you're going to have a lot less. You're going to have a lot less of those negative emotions going forward when you're working with the client. So it's one of the two things that I try to do at the outset of meeting either a new client or resuming with one that's returned is to overtly state specifically that, they haven't lost their status as a human being, that they're person first, patient second. I use that one. And you have to, you could talk about person-centered stuff all the time, but if you don't actually say concretely, yes, you are a person, that sometimes doesn't get picked up. So, saying something like that, and also the attitude of, treatment is not onerous and can be a fairly pleasant place to be, and creating a certain atmosphere that's congenial, I think goes a long way towards allowing people to open up. And by so doing, you access some of the deeper, darker emotional strata that can be sustaining some of the using, such as shame, which is a place where I try to go to, especially after I've explored issues of trauma. I've been looking into Brene Brown's work. You can find her on TED Talks on YouTube. She's really good. But if you look into her stuff about shame and using vulnerability as a way of accessing shame and then going from there, it's been pretty useful from my experience. That being said, I'm sorry.
No, I was just going to say that's really great. And I appreciate you reiterating, again, all these, the person-centered ideas that we are bringing up. And I know the slides were kind of busy, but that was one of the things, highlighted in there was meeting people, where they're at. And I think, what we learned from all our colleagues, you said you could learn from social workers. I probably did too. I think, the challenge sometimes with our bent as physicians is, what do you mean you don't want to be well? You got to be well. Well, you're not well if you're using substances, and, how dare you come back and you're off all your meds. And sadly, sometimes that's the way, not just physicians, but other, people can approach clients, but it's not, like we're saying, it's not person-centered. I think that, like we said, any progress is great. And truthfully, like you talked about relating to people as a human, I was always really glad to see my patients. I really was. Even the pains in the neck sometimes, even especially if they had been away for a period of time and they show up and maybe they're not in the best of shape, but it's a relief, that person, that human that we've connected with is still alive, and that we can hopefully, sit down with them and work with them again and get to those issues like you talked about shame, dealing with people's vulnerability and getting them to look at, what goes on that keeps them going back to using substances. Because people, there are the biological pieces, but there are those other pieces that get people going back again and again. Talked a little bit about Oliver. Perhaps it had something to do with social connection, because maybe his brother was using or other people, but something gets people going back. And it's that may be a piece of it, but we know that he had schizoaffective disorder. We wondered about trauma for him. So something keeps him going back to the substances. And if he's there, we can help him look at that.
Hopefully. I mean, I think with especially our guys here, you're playing the long game. Expecting reductions in the short term, probably not going to happen. And if you do, how long is that period of sobriety going to last? So, looking at the long game for not being focused on abstinence or drug use reduction, but looking at prolongation and improvement of quality of life is kind of a different attitude that's helped me. I'm not looking like you have to use 10% less crack per week for the next 8 weeks. It's, can we keep you alive longer, and is your quality of life thereby improved? So that's I think important.
Yep. So I'm conscious of time because we do go till 11:30, but I know sometimes people have to leave at 11. So I do want to make sure we address Mary Peterson's question. So I'm going to read it out, and I'd really love it if the audience can jump in and with some thoughts about this, and Dr. Deutsch, of course, your thoughts, or anybody else of my state partners who are working on this with us. So the question is, how do you manage groups where some clients are not wanting to be in the sessions with clients who openly talk about harm reduction and not abstinence? We are feeling the need to run two different models, which is problematic. So. So again,
do you want me to say what we're doing here at the clinic?
Jeanette, absolutely. Thank you. Go right ahead.
Okay. Yes, I agree with the statement, and the way that we decided to handle that was actually running two separate groups. Right now, because of COVID, they were stopped, but we're trying to put the group together to restart. So we had one group that was called ABCs of Addiction, that it's for those that are still actively using. So the focus is completely different. And then it goes with the harm reduction and, you know, stress management, way to cope, your cravings, the full understanding. Then we have the other group, which is the Recovery Road, which is for those that have been sober for a period of time and want to maintain their sobriety. And what is interesting about that group is that they are all on the same boat and they have been bonding with each other. The other group is a lot of like in and out, different people, different faces, but this group is more consistent and is tighter. And some of them have developed social connections, and they see each other outside the clinic. They do activities together, because that's another thing, you know, is with the people, places, and things. So they had to change their friends to be able to maintain their sobriety. So this is also providing for them that outlet. Who would it be? So these people, you know, you're opening up, you're talking about certain things, you have these things in common, these roadblocks in common, and we are both focusing in doing better and maintaining what we work so hard to achieve.
Right, so thank you. So just in summary, again, you run two different types of groups. So there's the harm reduction focused, and then there's the people who have a period of time where they've not been using, and they're in a different cohort. Mary, I don't mean to pick on you, wondering how that sounds to you, or if you're still on, or if other people have thoughts they want to put in the chat about that kind of model, if they do that kind of model, or there are challenges to that kind of model.
Hi, I think that makes good sense, and that's kind of the direction that we've been feeling we need to go. It feels like the old phase 1, phase 2 approach, you know, for some of my counselors, and they've been really trying to adopt a very broad harm reduction approach. So they've been feeling like they shouldn't do that. So we've had a lot of conversation about the benefits to possibly separating these populations when it comes to the group work. The time we have run into problems, though, is when someone relapses, and, you know, sometimes that group focused on sobriety and abstinence then, you know, can feel violated or feel that, you know, that individual may not be working the program. And, you know, so we've also dealt with some interesting counter dynamics. But we just continue to talk about it in the team and go whatever direction the clients need us to go.
So if someone's in the more abstinence-based group, and they have a period where they return to use, so do they go back? Do they go into a different group? I guess I'm just curious, because
no, we don't have. Yeah, we don't have any. We don't have any rules about any of that. It just comes up as a group dynamic, and you know, I think my counseling staff is growing in terms of their ability to just stay client-centered and not talk about rules and models and everybody doing the same thing. So it's just been an interesting transition.
Mm-hmm. Thanks, Mary. Yeah, no, so when I ran a program at the VA, and we sort of had a similar approach. If someone was in a more advanced group, we did have like a phase 1, phase 2. So for a phase 2, where people had a period of not using and someone did return to using, obviously, if it was a serious period, they needed hospitalization, that's one thing. But if there was a short-term use, but we would want them to process, you know, in the group as much as they could with it about what happened with their use, and try to kind of get them back on track. But I think it kind of, you know, keeping people in that way, if you can, you know, again, if someone's gone for a couple of weeks or they need the hospital, it's one thing. But if someone has a slip, so to speak, you know, sort of, you know, trying to deal with it in a person-centered way, because also the group gets it. You know, the group really understands, because most of them have had slips, and to keep them, you know, working with the group, that has been helpful, you know, to them, you know, can be really a bonus, and to not feel that shame or that stigma of, oh, I used, I'm bad, I have to, take 6 steps back, again, whereas when being with that group, like Jeanette talked about with the group at South Beach, people really bond and have good experiences with one another. And again, being with that group when you've had a slip or a short return to use can be, really incredibly helpful.
I think the biggest positive shift I've seen with the openness to harm reduction is creating an environment where clients feel less shame talking about relapses and slips. And it's moving away from a model that I think was encouraged before, where clients felt that they had to hide that behavior, that something punitive might happen if they were more open about it. And we've had a lot of discussion in our agency about creating an environment where it's okay to talk about that. There's no judgment, there's no shame, there's no punitive consequence that's going to occur. So I see that shift to harm reduction being very empowering. And I'm happy with that.
Great. Yeah, I'm happy to hear you say that, because I think also when we do these harm reduction approaches, people come back, right? People stay in treatment. They may go away for periods of time and they come back. And when people are coming back to treatment, we can engage with them. We can help keep them alive. Because as we talked about earlier, with the opioid crisis, with the wide availability, either intentionally or unintentionally, of fentanyl, which we know is a much more serious opioid and overdose than others, that someone coming back and we can engage with them and do harm reduction with them, that keeps them alive. And if they're alive, they can keep working towards their goals, whatever those may be. So, Mary, really appreciate you sharing, appreciate you asking the question and then coming on and sharing what your experience. Also, Jeanette, thank you as well for sharing what you do, because really the goal is keeping people engaged, and keeping them alive. Okay, I've done a ton of talking. I don't know if other people have questions or things that they want to bring up, or if any of my colleagues who've been working with us want to raise any issues or questions or thoughts. Again, we do go past 11 o'clock, but we do know sometimes people have to jump off. So if there's some burning issue or question someone has, and now, or, they want to get it in before 11 o'clock or comment, please do.
Dr. Hennessy, I don't see any questions coming in, so maybe we can transition over to our brainstorming.
Sure, absolutely. So one of the things that we were thinking about, and this was sort of a question again for people who are attending, so less so, for Dr. Deutsch, thank you again, and Jeanette for, doing this case, but for other people, who are on the call, so we talked about the case. I went through my slides. We talked about some other harm reduction, person-centered issues. So in hearing all the things that we've talked about for people, again, who are on the call, what person-centered care, what other strategies could you use working with someone like Oliver other than we spoke about, and thinking about re-engaging people in person-centered care. So do people have any thoughts? They want to unmute themselves or put them in the chat, that would be great. We have a quiet group today, or everybody's typing long answers. I mean, maybe another way to think about this is, are there challenges that you have in delivering person-centered care? Is that, what are the challenges that come up? Your own clinic-wise, we talked about some clinic issues with Dr. Deutsch and Jeanette about people having to have their intakes all over again, and how to make that better. Are there things that people want to talk about, about themselves? I think, one of the things that we think about is that our own disappointment, maybe in ourselves, when patients return to using or they're not doing well. and how that might affect us and how it affects our ability to give person-centered care.
I'd like to add to that.
Please.
Because I think it's really, patients who are in pain or who are like, okay, and come back to treatment's no problem. But when you've been assaulted by a patient and then you have to continue to work with them, I think working through a lot of those resentments, some of those fears can get in the way of what you want to do. So I think it's not so much at the easy end, but if you've ever been really assaulted by a patient, you kind of know what I'm talking about. And what do you do then?
I think that's an excellent point. I think, in a related way, in physical assault, also people are verbally assaulted. So we've all been yelled at by patients, or unfortunately, sometimes some of us have been sexually harassed by patients, and you don't have, necessarily options to trade them out. So I think it's these are really good points to bring up. So Maureen Italiano put in the chat, it seems intuitive, but when someone returns to care, asking them what's the best way to support them, checking to see how the individual's goals may have shifted. How is this dynamic person different from the person you met the last time they were in treatment? So that's great, Maureen, thank you. So those are some great ways to engage people when they come back. So no, it's not intuitive, it's perfect. Thank you for sharing that. Other thoughts that people have, or thoughts about what Maureen shared? Or issues about challenges? I just wonder, I'll tell a quick story, just sometimes in the ways we feel about ourselves as providers. So when I was a resident, I worked with a lovely, lovely patient who also had schizoaffective disorder, depressed type. She had a belief that machines were controlling her in some ways. She did quite well in the community, but she had this sort of fixed belief about it, and also had depression at times, but really the psychotic symptoms were the primary, and she was quite lovely. And then she just did very, very poorly. Her psychotic symptoms got worse. She was really struggling. I was seeing her a lot. We did some changes around with her medications, and ultimately she had to be hospitalized. And she was in her 50s at that point, and she'd only been hospitalized one other time. And she was in her 20s when she had her first psychotic symptoms. And she was hospitalized, and within a day, the doctor was like, "You took her off her antidepressant, Grace?" And I said, "Well, yeah, she was complaining of side effects a couple of months ago, so we took her off of it. I took her off of it, and she wanted to go off of it." And he's like, "I think if we put her back on, that'll solve the problem." And sure enough, put her back on the antidepressant, and within, like a week or she was much better. She still needed some time in the hospital, but I made a huge mistake. I took her off her antidepressant. She complained of side effects. I did not put in another one. And it never occurred to me, because she had psychotic symptoms, that it may be because she was depressed. And 2 weeks after that, after she got out of the hospital, she came to my office and she said to me, "Thank you, but goodbye." Basically she was lovely about it. She was like, I can't work with a doctor who missed this. I'm paraphrasing because I don't remember 100%, but I remember the feeling still of how badly I felt that I was a resident. So yeah, maybe it was okay to make a rookie mistake, but this woman really suffered because I didn't think about the antidepressant, taking her off of it, and I didn't replace it. And so it felt awful. I still remember it like it was yesterday. I mean, it taught me a lesson about being more thoughtful. She was very gracious, but essentially I was fired. That was the first time I was fired by a patient. And this was not someone who was using substances, so a little bit different. But just feeling badly for a long time how I had hurt this person and really went through doubting myself. I think one of the great things was I was in a residency. I had wonderful supervision. I had a lot of supportive peers. We had our group and we would talk about these things. And, I got through it, but I remember her name. I can see her in my mind's eye. So, just sharing that story, so if anybody else out there has been like that, maybe you said something, if you're a prescriber, maybe you made a misstep with a medication, that those things can really affect us. And it can maybe get in our way of, delivering person-centered care. I can't remember, but I just wondered, did everybody suddenly get antidepressants no matter what their diagnosis was for the next 6 months after that? Probably not. But, it can change the way we feel, or could really put me off of wanting to treat people with schizoaffective disorder, because I might mess up again. So, so just sharing a little personal story, about how, again, we can kind of feel about ourselves when we treat people, and that can get in the way of our person-centered care. So if anybody has a comment or wants to put anything in the chat, we certainly would love to hear from you.
Chris, this is Rusty. I have a question for the group. I know we have a large number of people on the call, and they all have experiences and have been working in the field. And so the question is, it has to do with the harm reduction and the idea that sometimes you can't address the drug or alcohol use, but you could address the consequences that are affecting this person's life, the negative consequences, and see if you could reduce those versus reducing the substance use. So I guess the question to the group is, what has your experience been with that? Has that been successful? How have you gone about doing that? And I know there's people with lots of, I'm sure have a lot of good ideas on this stuff because of the work you're doing. Okay.
So-
Okay, go ahead.
I was just going to say, so there's a chat that says, can you please repeat the question?
Yeah, nice. I saw that. So, Mary, the question is, in a harm reduction approach, there's times where a person's not interested in changing their substance use, but they might explore how to lessen the harm related to the substance use versus the substance use itself. So what has your experience been with that? Is that something you've done, and what happened?
Yeah, I think for us, Rusty, we always go back to stage of change and motivational interviewing approaches. So we would try to interact with that individual in a very pre-contemplative way, where we're not really talking about any kind of planning for reducing use. And we have to be careful about how we talk about planning for safe use, because what we really want to do is be more pre-contemplative and just start them thinking about the pros and cons of what they're doing. I think sometimes when clinicians rush too quickly to setting up plans, we invite resistance that keeps people stuck. So for me, it always comes back to a real strong stage of change in the way we ask questions, the language the client is using when they're talking with us, and just trying to start conversations, just wide open conversations, with whatever the individual is interested in sharing, and then trying to look at the pros and cons, the dichotomy between what they say they want, what they're doing, that very pre-contemplative model.
Well, that's one terrific answer. Thank you.
So we had another comment in the chat from Suzanne Schulman. So one obstacle to person-centered care is the reality that therapists and psychiatrists have negative reactions to the pre-contemplative patients. Clinicians feel like they are working harder than the patient because they must chase after the patient, who are reluctantly engaged or actively avoiding treatment. It's an excellent point.
Yeah, you know, when that's happened to me a lot, where you feel like you come up with an answer and they tell you people tell you what's not, that won't work. I've already done that. And I always think when that's happening, you're probably in a different state than person is. You know, you want them to move forward, you want them to make changes, you want them to do all kinds of things. And sometimes they seem like they want that, but when they keep saying no, they're just not ready to make that commitment, to make that change. So, and I think it is hard for people, for us who are it's a helping profession, and we set out to help people. And so we have a lot of ideas what would be helpful for them. And when they're not interested, that's hard for us, right? And it's hard for us to back up and say, well, what is it that you want to do? I've said a lot of things what you might want to do, but what is it that you want to do? And sometimes they, it might not be, and I think, Danny, this is what you were saying around expectations. It might not fit in with what we expect people to want to do. So, and I think that's a struggle for us sometimes. And sometimes it's a worry, you say, how could we, here's somebody's using crack cocaine, how could we not really try to get them to quit? And will we be held accountable if something happens to them? Because that's another big issue. So I don't know what people think about that. Mary says, I feel your pain, Suzanne. It is painful for us.
I had an old supervisor. His name was Todd Murphy. He's in Long Island. And I used to, so I was the intern in the community mental health clinic. And whenever I would go see him about some principle that I felt, was violated, I would just rant and rave about it. And he would sit there very calmly and he'd let me finish. And he would say, what time is it, Donnie? I said, it's 11:45. He says, no, it's time to lower your expectations. And he threw me out of his office. That was a good lesson.
Yeah. That's great. That's funny.
Todd.
Suzanne said to Mary, I feel your pain. Thank you. And then she has this really interesting question. When you ask, what do you want to do? These patients will also often say nothing. So now what's the next response? What would be a response to that? What would you do? What do you do? We're throwing it out to the group.
Yeah. Or they say, I don't know. So nothing or I don't know.
Yeah, right.
So Suzanne says, wait.
Okay, wait. Okay. Don't, because this is the concept of not rushing people, not rushing ahead of where people are at, where they're ready to go. Because they'll end up resisting that. And sometimes people can get really upset and leave treatment because if they feel like you keep pushing them to do something they're not ready to do. A lot of times sometimes that happens when we kind of tell people to go into rehab, go to a rehab program. And, and that's not anything they want to do. And we think that's something they should do because it'd be best for them. this would be the, in some ways, it's like thinking that we know what's is best for them. Any other comments on that? Because that's a very important problem. Is what do you do? So Mary has something, she says, I'm curious about what keeps you coming in. How does your talking help or frustrate you? Okay, so really asking them what it means to even have a conversation with you and what brings them back. Jordan said, asking what's made you call and ask for an appointment. I wonder where the motivation to relink came from. So asking them why did you, I know you're having trouble to figure out what you would like your life to be like and, what things you're interested in doing, but what, and I'm paraphrasing this, Jordan, but what made you want to come back? What was it about what we do together that was important for you? Is that okay, Jordan? I didn't twist it too much, did I? That was perfect.
Nice job, Rusty.
Yeah. But it's interesting what people are saying because you want to make a connection. You want to have like a connection, like a relational connection. Okay, so you have to find where that's going to happen, and sometimes it doesn't happen when you try to. It usually doesn't happen when you're going faster than the person wants to go. So then they back up and find something that they might respond to that has to do with how you work together, how you relate to each other. Okay, so Nancy asked, what is the role of peer providers in engaging and in harm reduction? And Mary said, engagement rapport must be genuine. Sometimes we're the only ones with hope. Just keep sharing it. So that goes for, that's an important thing. And there's kind of a transparency in that where you can't be doing something to manipulate a person to making a change. You know what I'm saying? The idea is not to manipulate them. It's to engage with them and to build rapport. And it is true that hope is a big piece on our part, that sometimes people are hopeless and we're the one with the hope. And we have to say, we have to show that we really, see them as being able to do something. We have hope for them that they could really their life can be better. But it doesn't mean they have to make changes, but we just have that hope for them.
And I think, again, that goes back to meeting where people are, where they're at. We have hope for them, right? They don't necessarily have to change. And it goes back, I think Dr. Deutsch was also just that comment makes me also think about the human piece, is that, a wise supervisor once taught me, when you think about your patients or clients, like, when was the last time someone was glad to see them? When was the last time someone gave them a warm hug or a warm smile and was really actually genuinely glad to see them? And sometimes we're it. And so, Mary, as you point out, we have to, it has to come from a genuine place. And, we really need to show, our patients that we care about them. Sometimes that's hard. That's one of our challenges, I think, to providing person-centered care, like we talked about, is that, when patients challenge us in different ways, physical assault, the way they treat us, or they're just not nice people, we still always have to remember that there's, the other human is there. And that particularly when people are using substances, or they have untreated psychiatric conditions. And sometimes, again, in the light of what we're talking about, it's both. So they're using and they're not on their meds, they're not treated, they're not in their therapy. They're not always the nicest folks, but we always have to remember we have to cut through that piece and continue to hope and continue to reach out to the human that's in there. They may not have to change at that moment, but if they recognize we're recognizing them as a human, then they respond better. So Suzanne had a comment. So many of our patients are coming to treatment because of outside pressures from family or the residents where they live, not because of their own motivation. But I do like the suggestion to ask process questions like, how does our talking help or frustrate you? Great. Well, glad, Suzanne, glad you got that help. Thank you, Mary. I think, Mary, you were the one who put that in there. That's great. I'm glad you got something out of that. So I'm not sure anybody addressed Nancy's question about the role of peer providers in engaging patients and in harm reduction. Does anybody have peers in their programs and experience with that they may want to share? Or if you're on and you are a peer, you want to share your own experience?
You know,
Go ahead, Rusty. Yeah.
okay. I like Suzanne's question, and this often happens around engagement or re-engagement. If somebody is being forced to come, how do you engage them in a relationship if they don't want to be there? Any tips from the group?
So I'll jump in briefly while maybe someone's typing. So again, my pre-OASAS life, I worked at the VA. We had a lot of mandated clients, particularly legally mandated. And a lot of what we did, Dr. Deutsch mentioned it earlier, part of it was managing expectations. So, the patients had to be there because they had legal mandates. So we just made it clear, this is the program, you are required to be here. We hope you will engage. We hope you will get something out of this. You will have a case manager, just again, very concrete about what the expectations are. And, we would just kind of see what happens. They would have to meet with me for a psychiatric evaluation that was required as part of the program. Also, the courts usually wanted one. And sometimes they would be yes, no, yes, no, really not elaborating. So I would just meet them where they were at. If that was the psych eval I got, that was the psych eval I got, but I didn't get nasty with them. I didn't get hostile. I would just treat them like everyone else. And so I think that, again, that's Nancy's typing it down, still really meeting people, where they're at. Because especially if people are mandated legally, but even family pressure or other pressure, if they don't want to be there, they don't want to be there. I mean, we've all been in situations where we didn't want to be somewhere. not treatment wise, but just think about it in your lives and think about, you were like, oh, you know, like, really, I have to be here. When is this over? When can I get out of here? But if there was something pleasant about the experience, or something at least not negative, sometimes it was more tolerable. So, you know, our goal in the program that I was the director for is we treat everybody the same. Obviously, you know, we would work with them. We would hope they would get something out of the program, but, you know, you in some ways, you just kind of let them be like, we're here for you. Hopefully you'll get something out of this. We're going to treat you like we treat everybody else. Please, you know, this is what you need to do. And hopefully you'll have the same respect for us.
Sometimes I don't even talk about treatment. I'll just offer something completely absurd during the session. So I think during one session or one course of treatment, I worked with a guy on how to rob a bank. So robbing a bank is complicated. I mean, I actually have never robbed a bank, so this is all theory. But I know that if you want to rob a bank, you kind of have to be clear-minded. And if you want to be clear-minded and organized and socially networked so you can find other people to like blow the safe, I don't even know if they do that anymore, but you have to be more sober, because if you're not more sober, then you can't possibly rob a bank well. And everyone wants to do a good job. So you can use ridiculous situations to emphasize the points that you need, and it kind of gets past a lot of those defenses that are put up initially. That's something I've done, and worse, and worse.
Well, humor, this, I don't know if this quite fits in, but humor is a tool. You have to be genuine when you're being humorous. You can't be manipulative. But I think it lowers the tension in this relationship between you and the person, you know, if you use humor. I use humor a lot. People I work with didn't always find it funny, but.
Again, it gets back to that connection, right? We connect around humor. So
Yeah.
anytime, or absurdity. And, you know, I think it's a great example, because also, you know, we know who we are, we know who we are in the world, but sometimes, you know, again, patients, if they're new to treatment, they might be intimidated by us or think we're weird because we're psychiatrists or psychologists or social workers or peers or KSACs or, you know, fill in the blank. So anytime you also show your humanity by being funny or saying something absurd or giving a genuine smile, you know, then they realize there's another person there too. So even though we're treaters, we're also humans. And that, you know, when we are humans with them, that goes a long way as well.
Yeah, that's a good point.
Mm-hmm. So I just want to let our presenters know we are kind of winding down. We have a few more minutes. So I do want to give you just an opportunity to address any questions that are outstanding or any comments that you have. And if not, then we'll go ahead and close out. So, and again, if you have any questions that you'd like to address to the presenters, feel free to go ahead and do that. There are some slides, some contact information. So maybe Tara, if you can just share the, thank you. Share the deck. So again, thank you all for joining us today. We do have, again, many thanks to our presenters and our partners for today. We do have contact information for our presenters. And so if you are interested in learning more, you know, based on the presentation, please feel free to reach out to the individuals noted on the slide. We've also chatted in the link to previous presentation. So again, if you want to find out more and, didn't have an opportunity to join us earlier on, you can do that. Again, we want to thank Dr. Deutsch and South Beach for joining us not only today, but last month as well, and threading that case through. We really appreciate it. It was very helpful. And again, thanks to all of our partners for kind of walking us through the content for today. And so with that, I think what we want to do is just leave you guys a few moments to complete the feedback survey, if you will. Where, we really do rely and look at this feedback to let us know how we may make these offerings a bit more helpful. So if you can just take a few minutes to do that, we would appreciate it. And we do value your feedback, and we'd love to hear from everyone. And again, thanks for joining us today, and hopefully we will see you next month. Thanks, everyone. Have a good day.
Thank you.
Thank you, everyone.
Thank you.
Bye.
Bye.